Hello, everyone. Dr. Dustin here on another episode of The Dr. Dustin Show. It is Monday, 7 p.m. Central Standard Time. Welcome. Hope you had a great weekend. Tonight's going to be a little bit revealing. We're going to talk about numbers tonight. And actually, before we got started here with the show, Evelyn, who's here in the studio, say hello, Evelyn.
Hey, guys.
We were having an interesting debate or a conversation, if you will, about what is it meant when people say healthcare is a right. And this is an important question. I don't think anybody would argue that certainly there should be very little, if no barrier at all, to entry when it comes to accessing healthcare. At least in this country, I know myself and pretty much every doctor I know would want to treat every possible patient that we can. But the sad part about it is the potential for lack of sustainability or the ability to, continue that service, let's say free of charge, even if it's considered a right or however we're defining it, into the future. So if you're in the conversation tonight, we'd love to hear your opinion because that's sort of what we're, I don't want to say framing everything through, but it's definitely a consideration when we're talking about numbers and sustainability. So what were you saying, Evelyn, just a few minutes ago, this idea of healthcare being a right? How do you define that?
Well, I think in a perfect world where we're not looking at, because I think compassion cannot be found within numbers. And unfortunately, our entire society is built on numbers increasing and decreasing all the time. So when you make these things like healthcare, which are, at their base, compassion, into industry, into numbers, you lose that level of ability to care, ability to and maintain, that compassion, pure compassion.
Well said.
Yeah, so I think when it comes to healthcare, you can't be as compassionate as we probably should be most of the time because of in which the framework of our society is built. Capitalism stops us from being able to maintain a sense of pure, whole compassion.
Right. Yeah, we have godly endeavors in a worldly world, right? And so tonight, can be a cold topic for many people, perhaps an interesting topic to know sort of what goes on behind the scenes when it comes to dealing with numbers. But yeah, this idea of, healthcare being a right, I suppose just that statement alone sort of was a big pill for me to swallow, because as a provider who gives of his time and effort and blood, sweat, and tears, so to speak, the idea that somebody may have a right to my work, well, that was, not so great. It's kind of like God saying, well, we want you to love us, but we're going to force you to love us rather than giving you freedom of choice. It feels so much better in here when I can volunteer my time or decide to treat whoever I want based on whatever needs they may have.
Yeah, and I kind of said that that right does not necessarily mean obligation, and that especially looking at our world, capitalistic society, right in that sense, I would think, because we brought up, our inalienable rights, right? Like our negative rights.
As laid out in the U.S. Constitution. Yes. I know we have some viewers up in Canada, so you're familiar.
Yes.
But yes, we're talking about the United States Constitution.
Yeah, so he brought up, the right to bear arms, the freedom of speech. And then he was like, well, if negative rights are the only rights.
Meaning that the government can't take away something.
Well, then healthcare doesn't fall under that. And I said, well, what about our due process, right? That is something that is, you have the right to due process, the right to counsel. That is something that is given to you.
Great argument.
So I think within our capitalistic view right? Because in theory, we can give everybody everything all the time. You should be able to, in theory, go see who you need to see and, get taken care of. But in reality, that's hard to do. So I think within our numbers world, the right is the access to, is what I said. The access to find it, the access to seek it, to be able to go in and be like, hey, I want this. And of course,
to ask for help.
Yeah, to ask for help.
And pray the doctor shows mercy.
Yes, exactly.
Right.
Exactly.
Yeah.
And then we talked about emergency services.
So EMTALA would be the notable exception to this, where it is a law in our country to treat those who seek emergency medical services in the hospital. So hospitals are required, emergency departments are required by law to stabilize that patient medically, regardless of their need to pay, right? So now that is punishable. And you might say that is a human right in this country, in the United States, to be treated in that capacity. Some would argue it's more of a compassionate policy, right, rather than a right per se. But that is sort of the differentiation. It doesn't necessarily apply to outpatient pain management, let's say, right? Yeah. And again, as much as that we would want to help everybody, regardless of that, right? That is sort of the ethical oath that we took, right? To do good, to do no harm, all of those things, right? So we want to help everybody, but the question is also sustainability, not only for the business, let's say, right? If you're not making money, you can't keep the electricity on, you can't continue to see patients. If you're not paying for your medical malpractice or to maintain your licensure and the hundreds and thousands of dollars that costs every year, then you can't continue to see patients. So you absolutely require money to exist as a physician, as a practice. I don't think anybody would dispute that. And then just sort of figuring out how that fits into the bigger picture of sustainability, of incentives, and numbers. And that's sort of what we're going to talk about tonight. Yeah. All right, so let's see here. Many of you know it takes a lot to become a physician. I'm sure I'm beating a dead horse for a lot of you, but just to kind of guide you quickly through my experience, we had 4 years of college where I did a major in biology, a bachelor's of science with pre-med focus, and then 4 years of medical school. At which point, you choose a specialty. And then, so for me, I chose physical medicine and rehabilitation. That was a 4-year residency program to follow that. That first year of residency was the first year I got paid. Yay, hallelujah. But what's funny about it is when you take up your salary and you divide it by the number of hours worked, it's actually less than minimum wage. So, but whatever, I got paid to wear scrubs, so I was excited. And so we did that for 4 years, and then chose at the end of that period to subspecialize into pain management, which is an additional year of training before coming into private practice. So essentially a decade of little to no pay, of 80-hour to 100-hour work weeks, whether you're in the hospital or studying for tests, which occur on a weekly basis, it seems. And, and by the way, all the tests are make or break. There's no like, oh, well, try it again next year. No, the competition is too good for that. So you have to stay up with it every time. And then, but again, not only is that sort of, my own experience, but also consider the experience of my wife, who was a young mother at the time. We started having children through that period, basically an absent father, right? And so trying for her to live through that period of time, also sacrificing whatever she had in mind for living in a happy, healthy home, at least deferred, right? And even now, we're finally like steady, but it's a challenge balancing everything. It's not your typical 9 to 5, but again, I'm preaching to the choir. Many of you already know this. So how does this turn out when you're finally in business? Where are the numbers going? I think there may be a sentiment perhaps among patients. Feel free to correct me if I'm wrong, but perhaps a lot of patients feel that their pain doctors are only doing things for the money or making decisions based on the money. And I think that could be true. I'm going to show you some data tonight that may threaten that narrative. Actually, I was surprised myself. I thought that perhaps that was the case more of the time, but at least based on the data that I'm seeing, it seems like that's maybe the exception, not the rule, which is good news. So what goes into a medical practice? Let's start with that. The overhead involved, right? I think it's easy for a patient to see in the mail that, they go in to see their doctor. They spend 5 minutes with their doctor, and then they get a bill in the mail for $300. And they're like, what the heck? This guy must just be raking it in. No, not necessarily. And that's what we're going to sort of break down tonight. First of all, insurance. Let's talk about insurance.
Oh, no.
Oh, no.
Insurance.
Evelyn asked, what are we talking about tonight? I said insurance. She's like, oh, gosh.
I cried. I cried a little. Just one manly tear.
Yeah, nobody likes to talk about insurance, but we have to at least frame it how we were talking earlier. Yes. Okay, this concept of healthcare is a right. Okay, fine, but where do you go from there as far as sustainability goes?
Yes. And I brought up, again, capitalistic society, money, numbers, kind of erases compassion. I said that sustainability, I would look more towards like people across the pond, like France, where healthcare as a whole is a shared burden, just like we have, like our social services.
You're talking about universal healthcare.
Yes, universal healthcare. Yes. Mm-hmm. And unfortunately, I think when that topic comes up, we kind of shirk at the idea, right, of having to pay more taxes. But I mean, to allow healthcare be a right and allow for more compassion, it has to be a shared burden. And unfortunately, I think just like, we have our right to due process and right to seek counsel, yes, those are shared burdens, to pay for those counselors and for those government, programs, does not necessarily mean they'll be amazing. And I guess that's just the pitfall of capitalism. Like, it's either you pick the middleman, in some tall building, or you pick shared burden, but that means more taxes, and that means, so there's never escaping.
And I like that because it's realistic. Choose your villain.
Yes.
You're choosing the villain either in the shiny skyscraper, who is the CEO of the insurance company, or you're choosing your villain in the White House.
Yeah, absolutely.
Right. So obviously, lots of countries may claim success with a universal payer. I happen to be of a different opinion than you. That's fine. That's why we're on the show. My argument against universal healthcare might be from my people coming from Canada, who's watching us from Canada, because they have a universal healthcare type system. And I know one of the big arguments from folks south of you is that it can result in a significantly prolonged time of care.
Yes, I think as soon as we mentioned that earlier, Keith in the chat said, "Yeah, the wait times are crazy."
The wait times are crazy.
Yes, and I guess that's what I mean by
right.
Shared burden as well. It's just like you can get food stamps, but everybody who's ever needed food stamps or government assistance knows it takes forever.
Right.
I think it's just like those things. To pick the villain that is the White House would mean it takes a while and the wait times are long, but everybody has the right to it. But if we pick the guy in the skyscraper, some people will get care that's up here, and then some people will get care that's down here. And I guess picking the White House villain would kind of, in my mind, kind of go like this.
Yeah, yeah.
And it's not, that's not great for these people, but, come on. You know what I mean? It kind of evens the playing field.
Yeah. So, pros and cons to all of this. Obviously, this is a very high-level conversation.
Yes.
I have an idea. So, I've been tossing this around for a little while now because, from my perspective, in the society that we live in the system that we live in, I deal with commercial insurance. I deal with Medicare. Actually, right now, as it stands, Medicare is the easiest to work with. Why? Because I bill them. Of course, I make sure I do all my things right because they can audit my charts. And if I don't do all my things right, then they'll get me in trouble for Medicare fraud. And that does happen. I've seen it happen. So yes, there are people that, don't play well. But I play well. And in case you're Medicare, you've already audited my charts. So you can know that everything went well. That being said, commercial payers are a horrible thing to work with because they can decide not to pay you. They can put you through 10 different hoops to try to get something approved. Just the other day, I spent 11 minutes scheduling a peer-to-peer and then 15 minutes the next day performing the peer-to-peer for a service that I actually wasn't eligible to even be paid for. So that's basically 45 minutes, give or take, of my time, all considering, where I'm having to help this patient out of the goodness of my heart, but deal with the system that is horrible commercial insurance. So that's just one example. What I think would solve a lot of these problems, and I really would be curious to see if you're watching this video, leave a comment. If we treated health insurance like we treat car insurance. So the idea is just get the middleman out of the room. I don't know what it is about insurance that has sort of brainwashed physicians and patients alike for them to think that, well, I'm here to take money from you and not give it to you, and somehow both of you are going to benefit. Okay. Now, obviously, there's situations where insurance is quite helpful, and I'm sure that those people would be quick to pop in, and I wouldn't disagree. It's always nice to have insurance pay for things, especially for let's say pre-existing conditions or, emergencies that we weren't prepared for, that type of thing. But what if we treated healthcare or insurance like we did car insurance, meaning that our premiums weren't $1,500 a month. They were like $150 a month. And we didn't use our insurance for everything. Maybe we just paid cash to the doctor or preventative services or imaging, right? See, my perspective on that is it would drop the price. Because you're getting a $300 bill in the mail for a physician's visit. Okay? Well, that $300 bill is not what the physician gets paid. That $300 bill gets adjudicated based on the contract that physician has with the insurance company. And then there's a lesser amount. And then there may be a couple other filters that get applied. And so out of that 300, your physician may only get, let's say, 70. And you may only be responsible for 20, let's say, something like that. But for that 20 on your end, you have to pay the premium to your insurance. So still you're paying, really high numbers. And if you think about it, any standard, let's say, insurance plan, I know that I signed up for, or actually I could have signed up for, there's like a $12,000 deductible. There's like a $1,500 a month premium. And then there's a copay on top of that, or a co-insurance. So even after you met your deductible, you're still responsible for a certain percentage. So you may be out of pocket $30,000 in 1 year before your insurance covers everything. How often do we spend $30,000 on healthcare? Now, some of us absolutely do. Some of us don't. So how come we don't have plans that would apply for those folks? And the reason I'm saying this is because if you were using your insurance like car insurance and you come see me, I'm not going to charge you $300. That wouldn't be reasonable. You're not going to pay me $300. It's a supply and demand issue. I got to lower my rates. So maybe $50, something like that. That way, maybe I get $10 more than I usually do, but you also save
hundreds,
if not thousands, over the course of a year.
Absolutely.
Right? So trying to look at it like that, I would love to go back to how things were maybe 50 years ago, where, doctors made house calls, or you had a clinic and, you brought in your 2 chickens in exchange for healthcare services, or whatever the case may be. If we get the middleman out of it, the costs will drop. And it's sort of like the same thing with student loans.
Oh, yeah.
I feel like I have something to say on this, given the fact that I have like $400,000 worth of student loans. And this was actually a controversy lately, right? I think the Trump administration had changed the classification of certain healthcare providers to not professional.
Right.
So
That was recent.
nurse practitioners.
Nurse practitioners, physician's assistants are no longer considered professionals. Well, it's not anything to do with them not actually being professionals. We all know that they're professionals. But by changing their classification, it changes how much money they can borrow. And if you can't borrow as much money, then the universities that give these folks educations, they're not going to be able to charge as much. So actually, it's a great thing to not be able to borrow as much, because now it's going to force the reduction of your cost of education.
Right.
That's the only reason that drove up the cost. Oh,
everyone can borrow.
The government's going to give you $100,000 to come see me. What's my cost? $100,000.
Boom.
It was 20 because you're going to pay cash for it, maybe work as a janitor on campus to pay for it as you go. But now you can borrow it. So we're going to take 100. So I think that's the same thing that applies to healthcare. If you were to, and correct me if I'm wrong, take sort of that big middleman out of it that causes the cost of everything to go up. And by the way, I'm going to get into that. Insurance also increases my overhead tremendously. Think of all the bureaucrats or the billers or the adjusters or the people that do the pre-authorizations and the scheduling and all of that stuff back and forth to try to get paid, collections, all of that. That's like at least 15, 20% of overhead just right there to get paid.
Wow.
So when you remove all of these things from the overhead equation, then the cost between the patient and the physician, it's like, yeah, I'll take your 2 chickens.
Oh yeah. And that's worth it.
Yeah, but I guess that's where the numbers and the compassion fight. You know what I mean? That's the whole looking at it through the system of, you know, when you turn something that is for the benefit of our community into something that is profitable, like health, like anything else, any other social service we can talk about. It changes everything. You know what I mean? It is almost impossible to be compassionate to the level we need to be as a community. I mean, as a country. I mean, even in our own cities, you know, because everything is money. And what insurance does, I mean, I haven't been alive very long, but from what I've gathered, you know, it's kind of this. It's easy to be like, oh, okay, I'm going to pay this much every month and then I'll be covered. And then when it comes around to it and it's like, oh, but you still have to meet this number. It allows them to, it's like the 99 on your price on your Snickers bar or on your food. It's a mind trick to, you know, take more from you than you expect. I mean, because me as a young person, I rarely go to the doctor. I mean, it is not reasonable for me to pay for insurance and to meet that deductible and to do all that because I just genuinely don't go to the doctor that much. And I mean, I would only need it for emergency. And I think that's where it's kind of thinking about healthcare like, you know, car insurance. Because I think I'm not the greatest driver, but, you know, I'm not the worst. And I think, you know, knock on wood, right. I've done pretty good so far. Haven't needed it. So I have liability, you know, but that's it. I think that's all I have. So it's kind of the middleman is definitely a problem.
Well, we're trying to use insurance for changing our oil, filling up the gas, changing our tires, changing the windshield, all of these things. And in order for the insurance company to be sustained, they have to charge more than what they're putting out. So naturally, if you don't need to change your tires that month or that year or whatever the case may be, even though there's still a deductible, so you're still going to be running through thousands and thousands of dollars, you know, with the mindset or the comfort level of knowing that if you were to total your car, but why not just have the insurance there for the totaled car rather than all of the maintenance? But again, you know, I often live with my head in the clouds, so I'm sure I know nothing about this whole thing.
Yeah, I mean,
it's a high level discussion.
Yeah, it is definitely a high level discussion.
I think I'm just griping because insurance contributes so profoundly to my daily stress.
Yes, yes.
I'm like, there has to be another way.
Yeah, and I think of patients.
And I think I definitely think, especially me, if it's hard for Dr. Leek to talk about this, I mean, I shouldn't even be in the room. But I think, oh man, I lost my train. I lost the train. I think when it's definitely, to bring it up like that, definitely, especially me, it's kind of, I feel like it does come from a place of privilege. Like, I do have my health, and I don't go to the doctor often. And I think that there should be exemption, or not exemption, but exception. Consideration yes. for people who need the doctor all the time.
Of
who
course.
are always there. I think that's definitely, but for the most part, I think.
Well, but even for those people, I mean, this year, the premiums have been skyrocketing. I don't think that's any secret to anybody out there. And more so than ever, I've had patients ask me, hey, do you guys take cash? Because I'm not renewing my insurance. So I think, there's already a sentiment that's going that direction. I don't have insurance. I can't afford it. Imagine that.
A doctor.
I can't afford it. It's too much money. Part of the reason is my student loans are $2,500 a month. So how many bills worth of $2,500 a month can I sustain, and still feed the kids? So that's definitely the crisis that, America is in.
Yep.
And what solution can we talk about as a community to help solve that? I don't know. That's what we're maybe opening the door to tonight.
Yeah. I think, like Jennifer said, it seems like they just make up rules as they go, or make them so complicated that people can't choose the most beneficial options for themselves. And then earlier in our conversation, she said that she doesn't think we need to cap the salary, but taxes should be proportionate, and corporate welfare should not take priority over a country taking care of its citizens and investing in its citizens. And I think I agree in that statement.
Right. Yes, I would argue the benefit of America, what really launched it into the stratosphere, the practice of capitalism, has done more good for more people than I think any other system. That's my opinion. However, being someone from that background and that understanding, my views are shifting to some degree because this growing prevalence of what people might call crony capitalism. And it is, yes, a system that is designed to really help those at the top, and even destroy to the detriment even of the middle class, which is disappearing in this country, and with cost of living and everything else. So no, it's a very delicate conversation. I am not a political commenter, and this is not a political channel, but we are talking about numbers tonight, and so you can't really ignore
have
all
one
of that.
without the other. Yeah.
Oh, yeah.
The side that we're on is the side that helps the most people as possible.
Absolutely.
And so let's get into it. I know we've been kind of beating around the bush here, but let's talk about some numbers. So let's see. Where do I want to begin? Okay. So tonight we're going to highlight 3 codes that are commonly used in my clinic. We're looking at a 99214 code, 62321, and a 63650. And for all of you who are wondering what language I'm speaking, I am speaking Common Procedural Terminology, CPT codes. These are the codes that we give to our procedures, our visits, how we charge insurance, things of this nature. And so a 99214 code is probably the most common code that I bill here in the clinic for a follow-up visit. And there's certain criteria that apply to the different codes. Actually, a follow-up code can be a 99212, 213, 214, or 215. And so they're tiered based on severity. Essentially, the sicker the patient, the more medical decision-making I'm making, or the higher the risk that particular encounter involves, or the more time you spend with the patient, the higher the level of code that you bill. And so, again, most commonly done in my clinic for my patients is a 99214. When you take into consideration the overhead, so of a clinic, right? So you're talking rent, utilities, payroll, supplies, my own salary, which I come with a lot of costs as well, such as malpractice insurance and continued medical education, licensure and certification, business travel for conferences, and all these other things. It's a very expensive situation. In order to be healthy, from what I've heard and what I've experienced in practice, you really need to generate about 4 99214 codes per hour, which equates to approximately 4 patients per hour, 1 every 15 minutes.
Wow.
That's basically just to have a minimum healthy salary as a physician and make sure everybody gets paid. If that seems out of balance, then probably you're paying yourself too much, or your overhead too little, or whatever the case may be. That's just to get started. So think about that when it comes to starting a clinic. So when you have overhead is estimated to be about 70%. Anywhere between 60 and 70% of your total gross income. So if a practice, let's say, you're doing 4 patients an hour full time every year, let's say you generate around $1 million. Well, approximately 700,000 of that is going to go to overhead, and then that leaves the physician, let's say, with 300,000 before taxes and all the rest. When you're starting off, you have expenses before you have income. So that was the risk of what we accomplished here, starting actually in end of 2020, going into 2021 was our first year, the summer of 2021. Actually, they've written about this later on. I saw an article that said 2021 was the worst time in history to start a pain clinic. And here we are trying to open up shop, which makes sense actually, because for about, I would say 4 months, we had like 2 patients.
Wow.
Right? So when people are starting a clinic, they usually don't start right out of training. They usually go work for someone for 5-10 years and then get experience or comfort or whatever the case may be, and then take the plunge. For me, I knew this was something I wanted to do from the beginning because I understood pain management. I didn't want to do academics because it was often restrictive in what you could or could not do. Anytime you work for a big hospital system, you're going to be restricted. And you would think it's like opposite, like, oh, well, you're academics, you're cutting edge, you can do whatever you want. Not quite. There's a pretty strong political apparatus within any university medical center. So I knew that wasn't for me. And I didn't want to work for another private clinic because, well, they often get themselves into trouble. The people at the top are not always the most ethical. Yes, there are ethical clinics. I'm not talking about everybody, but there's enough for me to be concerned. And as it turns out, well, I can't say that because it's still too fresh, but let's just say I know people that bad things happen to. Anyway, but not here. So we wanted to, play by the rules, play by the book, do things the right way, care for patients in the best way we know how, be able to keep all the options available to us. And so here we are. But because we were starting something new, what are your options? You got to either take out a loan for $1 million so that you cover your overhead until you have patients. Because even if you have patients, it could still be 6 months to get credentialed with insurance. So you're still working for free for 6 months. Yeah, you may get back pay on that by the time you're fully credentialed, but you're still working for free for 6 months. So you got to have ways to pay your staff and yourself and all the rest of it. So you either take a loan or you do what I did and you just work 2 different jobs and come into clinic whenever your 2 patients show up, hoping you get more. No, but it was a good time. And it wasn't long before we had a full busy clinic that we do now. And thank goodness, because yes, our overhead is pretty significant. So let's talk about the 99214. What do you guys think a 99214 code pays? Well, I'm going to show you. And the secret to this actually is that it's not a secret. It is public information.
Can we take a guess?
Go ahead, take a guess, Kevin.
I'd like to see him guess in the chat as well, but a 99214.
This is a standard follow-up visit in my specialty pain management clinic.
and I have limited knowledge of any of this, but I'm going to take a stab and say a 99214. Now, this is paid out to the clinic or paid
Correct.
out? Okay. So
This is before overhead and all that stuff.
Right.
Yeah.
I'm going to say $120. That's my guess.
Okay.
Is it higher or lower than that?
Well, you just tell me. What do you think it is?
Well, I mean, well, I've overheard, but I think my number's really small.
Okay.
I was going to say like 45.
45. Okay. I wonder what they're saying. Oh, we got 120 in the chat, 260 in the chat, and 70.
All right. Oh, very good. All of these are pretty darn close. Why don't you pull up, Kevin? I think. Hold on now. Before you pull up the slide, pull up slide number 3, if you will. I believe if you put it in the order that I gave it to you. Okay. So yeah, if you go to cms.gov/medicare/physician-fee-schedule/search, I put that link in your email, Kevin. I don't know if you made a slide for that or not.
I did. I think it's this one. Yeah.
Okay, but I don't see the URL on this one. But
Oh yeah, no, I took it off.
okay, well, if you, in the meantime, I'll let you figure that out so we can at least, or maybe how about this? Let's just put it in the description for the video.
I would sure
because
can.
I want patients to be able to look this up. Part of the mission that we pride ourselves on is price transparency and all of that stuff, so we can all be on the same page. So yeah, so this is all published on cms.gov. As you can see there, the current procedural terminology, CPT. Go ahead and hit the next slide there, Kevin. So what you can do is search the physician fee schedule.
Wow.
Some of this stuff will auto-populate. You can see there the year you put in, and then the modifiers. I just do all modifiers. For the specific MAC locality, we're in the rest of Texas. So basically you can just click on the different drop downs there if you ever get curious and find your location so that you can find what Medicare reimburses per geographical region, because it does change throughout the country. Not dramatically, but a couple of percentage points perhaps. The codes we're going to search here, you can see there on the left, 99214, 62321, and 63650. These are all codes that I pretty much have by memory because I live, eat, and breathe this stuff. But you guys, this is probably a foreign language. So if you ever were curious, I suppose you could always just Google it. But as far as pain management goes, these are the most commonly done codes in pain management. So let's go to the next slide there, Kevin. Okay. So let's look at the bottom to start with, a 99214 code based on the location and all that stuff. You see a non-facility price of $131.75. So whoever guessed 120, you were probably the closest. Yep, 131.
I can't believe it without going over.
Yep, $131.75. Now, 70% of that goes to overhead, which is why I need to see 4 patients an hour just to make what I think I need to make at least. But that's the price there. And you might be wondering, what's the difference between a non-facility price and a facility price? A facility price is what you would get reimbursed within a facility. So like a hospital-based clinic or inpatient situation, but a freestanding outpatient type building is considered a non-facility. So we're going to look at that for a minute. Now, what's interesting here is the 62321. That, my friends, is a code for a cervical epidural steroid injection. Now, a cervical epidural steroid injection, you can do it in the clinic if you have the setup, if you have the nurse to monitor the vitals or the CRNA to give anesthesia if you decide, or the cost of the room, supplies, fluoroscopy, all of this stuff will contribute to the overhead there. So if you do it in the clinic, you get reimbursed at a higher number, at $265, because the idea is that goes to pay for the added overhead. If you do it in a facility, which is where I do mine, let's say in a hospital or an ambulatory surgical center, then you would get reimbursed $93.61. That is considered the professional fee, not the facility fee. So you might remember if you get a procedure done in a facility, you will have both a professional fee and a facility fee, and probably an anesthesiology fee if you decide to do that as well. But that is why. So that is just the professional fee, the fee that I get to perform your injection in a surgery center.
Before you move on, we had a question about the first one, the 99214, and the estimated 30 minutes. Isn't it a different code for anything over a certain amount of time? Like, what's the time? What's that for?
Yeah, great question. So if you look up what the criteria is for a 99214, it'll list a whole number of things. There's 3 categories. A lot of it has to do with medical decision making. And then, of course, you can bill for time. Now, if a complicated patient has, 10 different problems that you're dealing with that result in, let's say, a more investigatory approach that may require the prescription of, let's say, more dangerous medications such as opioids, and you're also checking the prescription monitoring program and running urine drug screens and reviewing certain diagnostic criteria, that would raise the stake of that encounter. Now, it's estimated that it may take a certain amount of time, but it doesn't have to take a certain amount of time if you check the other boxes as far as the severity of the case of the encounter goes. So that's one way to do it. Alternatively, you can bill based on time alone. So let's say, it was actually a pretty straightforward case, but, the patient just maybe spent a lot of time talking about, you name it, and there's, back and forth about the medical condition, but it takes a long time to cover all the issues. Even if it's a simple case, then you can bill for time in that situation in order to collect the same reimbursement for the same code. Does that make sense? It can be a simpler case, but if you spend more time, you can bill for time.
Yes.
It can be a complicated case and still not take the recommended time because it's just recommended. They're kind of giving you a ballpark of how long it could take, but it doesn't always take that long.
Okay.
In fact, probably most of the time it doesn't, but sometimes it does.
Yeah.
Let's go back to the slide there. So what I want to point out, because I think, we get a lot of heat. Pain doctors get a lot of heat for pushing injections all the time. Oh, we just need more injections. Oh, we just need more injections. I don't want to talk to you unless I can inject you. And maybe the idea is that we're just raking money over fist here. But as you can see, that is not the case. We're looking at $93.61 for a cervical epidural steroid injection, which means I get $93.61 to put a tip of a needle 1 millimeter away from your spinal cord in your cervical spine.
Amazing.
Hashtag not worth it.
Amazing. Amazing.
No, actually, I get paid more money to sit in clinic and write you a prescription, $131.75.
Wow.
Now, so speaking of incentives, it's kind of interesting there, right? But the $131.75, you have to take out overhead, so that's the difference there. So take home between the two, I might make more money doing the cervical epidural steroid injection, but I mean it's negligible. $20-$30 more to put a tip of a needle in your neck. No, not worth it, unless I thought it would help you.
Right.
Unless I thought it would help you. So that's the incentive there, which I was pleasantly surprised.
This is good information. This is blowing my mind.
To put this in perspective, the 63650, which is probably the next most controversial thing in pain management, you guys are getting some treats tonight. This is the code that we use to do a spinal cord stimulator trial. Now, this code is just for one lead, and typically a spinal cord stimulator trial has 2 leads done at the same time. So we would actually bill that out 2 times. And this is another procedure that you could perform in the office, assuming that you had all the equipment, or in a facility. Now, there's a big discrepancy between the facility price and the non-facility price. And that big discrepancy is because if you do it in a clinic scenario, a non-facility, then you as the physician or the owner of the clinic or whoever has to purchase those leads from the vendor. And those can be several $100s right there. So Medicare understands this, so they increase the reimbursement for you to be able to purchase those equipment and then put that into the patient. So that's the issue there. So really the professional fee, which is again what I bill, is done in the hospital or ambulatory surgical center, and that's $366.94 times 2 for 2 leads done for that trial. So I don't know, that's a little bit over $700 maybe what Medicare reimburses you for that trial. Very healthy reimbursement. I'm not complaining. Certainly more higher than the cervical epidural steroid injection. But what is interesting here is that, and I'll have to pull this up. I don't have the reference directly in front of me, but the accusation now, I'm already hearing it in the chat. Oh, well, that's why my doctor wants me to do a stimulator, so he can make all this money, or she can make all this money. First of all, it's not easy to get you to the point of a spinal cord stimulator. That's number one.
Oh, yeah.
So first, we have to filter out all of the patients that would be good candidates. That's number one. Not everybody is a good candidate, not by a long shot. And so if your doctor thinks that there we go. If your doctor thinks that you're a good candidate, then certainly you should ask why and perhaps what studies support the use of this for your particular case or whatever the case may be. Because that could be where the breakdown in communication is if you don't trust your doctor, well, have your doctor explain things to you. That's okay. But to say it's just for money, like I said, not only do you have to find the right patient, but then you have to jump through all the administrative hoops to get there, which a spinal cord stimulator, let's say you go forward with the implant, the actual device that looks like a little pacemaker, the battery that goes in the back is very expensive. I mean, probably north of $20,000 expensive. Wow. Right? So that's purchased by the hospital, reimbursed to the hospital by insurance. So there may be a small margin there, but it varies depending on the contracts in the hospital. So there's no way for me to comment on that. But that's my point, is that it's the cost of the equipment that drives that price up, not necessarily what the doctor goes home with. Right. So let's say, okay, in most cases you have to get psychological clearance. So there's time, there's visits involved, there's time involved. You have to get updated imaging, psychological clearance, make sure nothing else is going well. You may have to jump through the couple hoops of epidural injections, aka not making any money but trying to help you in order to, let's say, not only help you but perhaps even qualify you for a stimulator if the injection didn't help, let's say. And then the pre-authorization process is also pretty intense with the insurance. They don't necessarily want to approve this, so you have to spend the time or the resources farming it out, so to speak, to your trusted colleagues to get on the phone, to send records, to wait for records, to do all these things. I mean, by the time it's all said and done, the margin is smaller and smaller and smaller, right? It's not like, oh, push a button, money. No, that we push a button and then we try to get there as quick as we can so we can hold on to as much money as we can, because it's just blown out the window constantly. So there's that, and the volume difference between an epidural steroid injection and a spinal cord stimulator volume is tremendous. So I'll put these links in the description, but there was one letter to the editor that referenced, they were looking at some claims data, trying to find risk and all this stuff. Well, they referenced the fact that there's an estimated 9 million epidural steroid injections done in the U.S. alone per year. 9 million.
Wow.
That number seems high to me, quite frankly. But not too surprising in the sense that it is probably the most commonly performed pain management procedure done ever. And so, yes, 9 million per year is what that reference cited. As of 2018, now this is 7-year-old data, and it's probably more than that now, but I'm sure not tremendously more. They calculated 36,000 spinal cord stimulator trials done in the U.S. in 2018. So 36,000 compared to multiple millions. That's my point, is that we're not sustaining any great income by doing stimulators.
Right. Oh, yeah, that's true. Wow.
That's just not, the volume is not there.
Ain't even there, right.
The volume is not there. I'm probably doing 2 digits per year. Between, I would say, 20 and 50 per year. That's great. I mean, that's healthy. That's, we're not overdoing it necessarily. We're not underdoing it. Like we're targeting the patients that we feel benefit the most. And actually 90% of all of our patients move from trial to perm and are still successful with it. This was data given to me by my vendor actually, who tracks all this stuff because they get all the calls when it doesn't work. So, that's the secret to it is, again, individualizing care, applying it to the right person. And I would say the numbers argue for that as well. 9 million epidural steroid injections per year, 36,000 are done, at least in 2018. I'm sure that number's gone up since then as we've continued to prioritize, as a culture, prioritize procedures over medication management. Whether that's right or wrong, it's not the argument. The argument is that it's happening. And so I'm sure that there are more stimulators than that, but it can't be anywhere near the 9 million that are getting epidurals. So, this is challenging talking about sustainability. Let's go back to, I'm going to bring this all back. So bear with me. I'm going to bring this all back. What dictates then the practice of a physician? We're talking about incentives.
Right, where they get their numbers from.
As far as risk goes, it's and comfort and ease, it's way easier just to write prescriptions. Why would I ever risk doing a procedure and making a patient unhappy doing a procedure, for what? An epidural, actually, I lose money. When you consider the overhead involved in all that, it's ridiculous. It's a loophole. It's a service. I want you to feel better. Let's try this. That's what it is. A stimulator, yes, there's money to be made. There's no doubt about that. But again, the volume is not there to make it any kind of practice changing. Everything needs to go this direction, or I'm only going to do this. No. Now, there's some patients that, let me put it this way. There are some doctors that I would say misuse spinal cord stimulators that I've been aware of and been made aware of, let's say even by certain vendors who are like, hey, I know this guy, I wouldn't work with him.
They're almost like pill mills, but for stimulators?
Pill mills for stimulators. So they'll use a different lead brand than a different battery because both of them are the cheapest when they're not really designed to go together. They will turn up the stimulator all the way, whether the patient needed it turned up all the way or not, in order to drain the battery quicker and then justify replacing the battery, which generates more income. So there are definitely bad things, bad players. I'm not saying that. But by and large, nobody is sustaining their practice off of spinal cord stimulators. The volume is not there. And vendors don't like to work with those doctors either, by the way, because vendors also like consistency. They like predictability. They like ethical practice.
Sure. At
least all of the vendors that I've worked with. And, it gives everybody the EBGBs when they start behaving in such ways. Not to say it doesn't exist. That's the sad part. But by and large, I would say that is the exception. At least that's my opinion. So what dictates then? Is it money? I mean, money is always a factor. If we're not getting paid, we're not going to stay open. But at the same time, I don't think it's just because we like doing procedures. I know plenty of board-certified pain management doctors that don't feel comfortable doing spinal cord stimulators. They might refer them to me to do a stimulator. It's not like they don't believe in the treatment, but they just don't trust necessarily their surgical skill, let's say.
Sure. Yeah.
And mad respect to them because that's putting the patient first, right?
Oh, yeah.
So, there's that. There's, your comfort level with epidurals. There's comfort level with, fusions. There's comfort level with prescribing. So at the end of the day, is it really money? I don't think it's really money that causes us to make decisions. And I know I'm going to get a lot of haters in the clinic in the comments for hearing a pain doctor say that, but it's actually been more my experience that it's the level of comfort that you have with yourself, with what you feel like you're capable of doing, with what you interpret the governing bodies to, step in and regulate you with, and not wanting to, ruffle those feathers. That seems to me the bigger play in what dictates, patient care, doctor decision-making, things of that nature. which is why a lot of doctors do academics. There's safety in academics, right? You're not going to get, your pantsuit off of you. Not likely. You have the protection of a major university and all of the resources and lawyers they have to protect you. Chances are they're not going to promote or even push the prescribing of opioids. A lot of times they'll defer that out or say, no, thanks, right? I think I mentioned this earlier in my show a few times back, that the training I got on the actual monthly prescribing of long-term opioid therapy in fellowship training was very little, if any. They just don't do it, in university situation. Peripheral nerve stimulators, again, not a huge thing. You would think that they'd be very cutting edge, but really they're not. And nothing against them. Everybody needs to have a role to play, and that's fine. But really, I think it's the country doctors that tend to push the envelope because there's really nobody around. Like the buck stops here. You got to do what you got to do to help your patient. So I'm going to learn this new technique. I'm going to learn this new approach. I'm going to figure out if this new medicine is going to help or not, because who else am I going to rely on? I think so. To kind of conclude, I think that's probably the main generator behind why your physician is making the decisions he or she is making. It's their own comfort level, and that's okay. We want our physicians to be comfortable. If they're getting uncomfortable, then I would be uncomfortable as a patient.
Oh yeah,
for sure. Kevin, why don't you pull up slide number 1, and then we'll slide number 2, and then we'll wrap this up. So these are some numbers, sort of like where we're going. So the difference in total operating cost per physician. So if you look at non-surgical, which I guess I would fall into as a pain management specialist, I'm not primary care and I'm not a surgeon, although I do minor surgeries. I think by classification, I would be non-surgical. And we are physician-owned. So the cost of overhead, you can see there, over the last 10 years up to 2023 has gone up 60%. 59.45%, 60% and up in overhead costs. Look Crazy. At the next slide. Yeah, and so Medicare physician payment has declined 33% over the last 25 years when adjusted for inflation. So, that's pretty crazy when you think about it, which is why we were talking about where do we go from here? At some point, those numbers are going to converge. Uh-huh. At some point, the medical receptionist is going to be taking home more money than the physician owner, at which point it becomes a non-sustainable practice. And so that's the big question mark for tonight. How can we maintain the incentives necessary to continue to promote high-level, compassionate care that you all deserve, that we all deserve?
Right.
That's the big challenge. And I don't know that we're going to have an answer on this earth. It may just be a short prayer to God and hurry up so he can get down here and take us to a government that actually works for everybody. But
well said.
But that's the cold truth, guys. That's the cold truth. I hope that there's some good news that we can take from this. Hopefully some interesting transparency that can maybe even boost your confidence in what it is that you're subscribing to. And then also ask the questions. What should we do? Where should we go from here? The reimbursement line and the overhead line are going to match on our current trajectory and not too long in the future. And I know medicine isn't unique. I know it's affecting many sectors in our economy. It's a very difficult time right now for a lot of people.
Including doctors.
And, well, we're still here, Kevin.
True.
I'm still making a paycheck. I'm not complaining.
Right.
But it is getting harder.
I'm seeing.
It is getting harder.
I'm seeing the numbers.
It's the canary in the cave, okay? Like the trajectory is not going in the right direction.
Correct.
So, what millennial or what Gen Z out there is going to come up with the solution for the next generation? Because that's what needs to happen. That was a Gen Z reference.
I was going to say, Evie, we need some answers there.
Oh, yeah. Well, I mean, I hope so.
Yeah.
I know we have the fire for it. The anger, the drive for change. So
I was going to say nothing to lose.
yeah, nothing to lose.
Right,
yes,
right.
definitely.
I don't know how many times we've had that conversation, but
Absolutely.
yeah, the generations that have gone before us, I think, are pretty well rooted in their expectation of what they expected to get, and they're getting it to a large part. And millennials were sort of sold a bill of goods and then said, okay, go for it. And then everything just kept getting taken away one piece at a time until we run ourselves ragged into the ground. And then Gen Z hits the scene and they're like, what's up, guys? We got nothing to lose. Let's change this system.
Yeah. We have no expectation of, we have no dream to strive for. We only have, our picture of perfect has always been in shambles. So.
Perfect.
Yeah.
On that note,
Sorry.
any good questions from the chat before we conclude for this evening?
Well, we had one talking about whether it would be similar in Canada, and I said, we're U.S. based, so I don't know if we could comment quite the same. But
As far as the reimbursements go and all that stuff?
Yeah.
Yeah, I really don't know. If I were to shoot from the hip, I bet it would be lower. Because in my experience, universal health care has resulted in significantly lower reimbursements to physicians. And so to have a private practice in that setup, you almost have to charge cash and sort of be apart from the system, which is sort of how I understand Europe to practice. There's the cash patients for the elite, or the cash doctors for the elite, and then everybody else gets universal health care. Similar to how we have the VA here. It's a shame, I think, that the VA operates the way that it does, because these are, some of the most deserving people in our country to get the health care that they need. But the VA is in shambles, man. I spent 5 years there, and the stories I could tell you, man, it's like, is this even real? Is this even real? Are we in America right now?
That's the crazy part about it.
And that's my big concern about universal payer in this country, because now we're going to turn everything into the VA. The hope is that it's executed more successfully.
Yes.
But yeah, I don't think, to answer that question, I don't think doctors get paid any more or even the same in under those systems.
Yeah.
Yeah.
Keith had a question on how many more patients you need to keep the lights on.
Oh, thank you, Keith. No, I'm actually pretty full right now. So, but if you are a new patient, we'd still love to make room for you. One of our goals here is to treat and set free as you're treated, feeling better. So no, we don't like to hold on to if we don't help it. But if we have to hold on to, well, we sure would love to do that too, because our goal is your goal, and that's to live more with less pain. So, yeah, good question, Keith.
I got a brief question here real quick. What's your perspective on the whole introduction of, AI and robotics coming into the space? Is that something that you think is potentially going to help drive down the cost, or come somewhat as a
I have a very
competitor?
dystopian viewpoint on that, but I can give it to you in 30 seconds.
Sure.
AI is coming. Doctors are going. NPs and PAs are going to be the human touch, and AI is going to be doing a lot of the medical decision making. NPs and PAs are going to be reviewing and signing off on that, maybe making adjustments based on their clinical decision making, but a lot of it's going to be AI driven medical decision making. And MDs are largely going to go out of style, maybe more put into administrative or consulting roles.
Wow.
That's my 20-second take on that. How far into the future that goes, I don't know. Obviously, there's strong lobbies on both, but definitely the prevalence of doctor shortages has been a concern. The idea that NPs and PAs are going to be the saviors of delivering healthcare, that has continued to rise. And there's a big push for that. I mean, it's a great job. I'm not downing on NPs or PAs, more power to them. I got family members that are NPs and PAs. That's a great job, but that's definitely the future. It's not physicians. Yeah.
We had a couple of questions on whether you think a younger doctor would be better. Would it benefit me to find a new young doctor just starting out as far as ethics and compassionate care?
especially if they're handsome like you. By the way, they love your the new look that you have
Yes,
for
yes.
today's
We had
stream.
multiple people notice you don't have your glasses on
Yeah, no
or your
lab
coat
coat
on
or
today.
anything. Yeah.
You know, this is my money shirt. We're talking money today.
That's okay.
That's my money shirt. Wow, you guys are so kind. Thank you so much. No, so what was the question? I got distracted now.
If young doctors are better for ethics and compassionate care.
So not universally. I would say not universally. If you were to roll the dice, yes, I would say if you're going to roll the dice. But there's definitely there's definitely young doctors that are there to make a paycheck. I'll tell you that right now. Yeah. Definitely young doctors there to make a paycheck. And I mean, you can't really blame them. They just spent 10 years living in poverty, working their butt off, doing, God knows what. And, calculating up, $500,000 worth of student loans, and they got a family and kids to feed. Yeah, they're going to try to do whatever they can to make money. Yep. So you can't really fault them on that regard, and I don't think that they're necessarily making unethical decisions, not all the time. I mean, I think you can do both. I think you can strive to earn money and be ethical in how you strive to earn money. I don't think it's separate necessarily. But yeah, I think also the longer you've been in practice, generally speaking, the easier it is to get jaded, the easier it is to look at patients as a number, to try to make, more money or whatever the case may be. But it's really hard to make money in this field ethically. And you have a lot of people looking over your shoulder, whether it's colleagues or insurance auditors, Medicare, the state. I mean, it's really hard to make a lot of money unethically. I'll just leave it like that. So you gotta practice within the rules, generally speaking, if you want any kind of sustained realization of your work. Yeah.
That's crazy. It's hard to make money unethically and seemingly just as hard to make it ethically.
But young people are scared. Young doctors are scared. They're scared of messing up. Right. And that's okay. But as a patient, you can capitalize on that too. Maybe you get their opinion and then you go to a more experienced doctor to have the procedure done, But I mean, yes, if you're going to roll the dice, I would tend to think that a younger doctor, because of, they're still in that fresh, I'm going to save the world mindset, that yes, they're going to make a good decision for you. Now they do lack experience, but that's not to say that they're not experienced. It's just, they haven't been doing it for 20 years.
Sure.
But that may be a strength. So I don't know. I don't think there's any clear cut way to describe that, actually. I think it just depends on the person and the relationship you have with your doctor. Yeah.
What would be the one word that you'd take away from tonight if it were one word or one short phrase?
Sustainability.
Yeah. It's
sustainability. Like I said, this whole operation costs a lot of money. Kevin, we've talked about this in this channel. It's sustainability.
Right.
If things don't at least pay for themselves, well, we got to reevaluate, because eventually every doctor will run out of things to give if their own cup is not being filled up too.
Correct.
And it's not even the doctor's cup. It's the doctor's family and the children and everybody that depends on that doctor as well. And them realizing the sacrifice, the benefits of the sacrifice they made as well. So yes, I have a lot of compassion for doctors. I am one. I have a lot of compassion for patients and dealing with the system that they're given, that we're all obligated to operate in. It's very challenging. And the one thing that I think can sort of go above and beyond all of that is relationship, transparency, and just being open and honest about what you guys are trying to do from both sides of the fence. And from there, I think a lot of good things can happen.
Well said.
Yeah.
Well said.
So on that note, I do have to run. Thank you so much for joining us tonight. We have a great week coming up. Tomorrow, Jose is talking about how back to insurance, can actually impair your ability to participate meaningfully in a physical therapy program. So don't forget to tune in for that, and we might have some solutions for you as well. Until then, take care.